that we face with some of our LARCs and really discuss some evidence, which I think we need to talk about a little bit more about our LARC methods and the extended use of them. So contraception is vital for the prevention of unintended pregnancy, and unintended pregnancy is a serious epidemic. We are living in the DOMS, the post-DOMS rails, and where contraception might be our next attack that we face. Mifepristone has recently been under the spotlight, but Plan B and emergency contraception has always been the next agenda. So that might be the next thing. So this is an important discussion for us to talk about what we as OBGYNs can do to really start on preventative measures to help our patients and women navigate the system. So LARCs, contraceptive methods that they provide ongoing contraceptive effort with little effort on the patient's part. So as a result, they are really the most effective form of contraceptive methods available. They fall within two categories of contraceptions, which is the intrauterine contraceptive device and your contraceptive implant. And as you can see from this diagram within the red box, the contraceptive LARCs are the most effective form of contraceptives. So who is a candidate for LARC? Just women of reproductive age who really desire a highly effective contraception, who desires a reversible contraception, and they can either be nulliparous or parous. So in 2010, the US for Disease Control and Prevention published an evidence-based medical eligibility criteria for contraception that we'll call MEX for the remainder of this presentation, and the college has endorsed it. And then in 2022, they updated this app and eligibility criteria to include different conditions and for a contraception. The conditions are assigned from 1 to 4 categories based on their levels of risk. So, for example, category 1 is a condition for which there is no restriction for the use of the contraceptive method. Category 2 is a condition for which the advantage of using the contraceptive method generally outweighs the theoretical or proven risk. Category 3 is a condition for which the theoretical or proven risk usually outweighs the advantage of using the contraceptive method. And then category 4 is a condition that represents an unacceptable health risk if the contraceptive method is used. This is demonstrating what it looks like in the app. It's also available on the website. So if you were to go online, you would be able to find this. And I've highlighted in the box here, the ones that we're talking about today, which are our LARCs, to show you, for example, if someone has liver cirrhosis, you can see that most of our LARCs are category 1 for that individual. This chart really illustrates the contraceptive methods that are used by women in the United States ranging from age 15 to 44. This is actually a kind of an old chart, but I couldn't find anything more recent, and this is from 2010. 38% were not using contraception at that time for various reasons, but 62% were using contraception. Of that 62%, though, only 4% were using IUD, and 1% of them were using implants. So LARC methods are associated with high satisfaction. This table is from the ACOG Practice Bulletin that explores the data from our Contraceptive Choice Project, which is one of our best contraceptive project research that we have in our family planning world. It had a cohort of over 9,000 women, ages ranging from 14 to 45, who were given the opportunity to receive methods that they wanted at no cost. So cost was not a factor. 75% of the cohort chose LARCs, and of those, 46 chose levonorgestrel IUD, 12% chose the copper IUD, and 17% chose the subdermal implant. The continuation rate for participants who chose LARCs were higher than those that chose the shorter acting contraceptive. And by shorter acting, I'm referring to like pills, Depo, Denuvaring, so on. So let's dig a little bit deeper and get in depth and talk some more about our intrauterine devices. So about 12% of 12% of contraceptive users in the US are using IUDs. That is more than 7.2 million people within the US in 2015 were using IUDs. IUD rate initially had declined about 7% in the 1980s, and even further down in the 1990s because the Delkin sheet had the braided strings that were causing some people to get more infection, and they were becoming infected with PID. So there was lots of distrust around the device. However, its increased use has been really because there's been a lot of safety feature changes and there's been improvement in the bleeding profile, especially with our levonorgestrel IUDs. And there's been lots of interest and uptake for non-hormonal form of contraception. This picture here is depicting a little bit of history. When I do any kind of presentation, I like to talk about the history of where things started. And as you can see here, in 1950, we thought, there has to be some kind of contraception. And it was there was some first approvals there. And then in 1971, or copper IUDs, there are lots of different types of copper IUDs. They came along on the market. And then in 1988, we had like 12 different brands of IUDs that were available in Europe. The implant is a younger version, and so was not approved until 1983, and had higher and then got approved in the United States in 1991. So it's a younger baby, but still a very great contraception. IUDs come in many shapes and sizes, as you can see from this picture here. There are both varieties of hormonal IUDs and varieties of non-hormonal IUDs. Some of the IUDs are noted here are still in use, and so I've circled or put a box around the ones that are still in use and that are still currently available. The most common ones that are available are the T-shaped and are most commonly some form of copper IUDs. There are currently 5 IUDs approved for use in the United States. You have your Paragard, you have your Mirena, and your Liletta, which are the same products but from different manufacturers, and Kylena and Skylar, which are also levonorgestrel IUDs but are smaller devices and therefore have lower dose of progestin. There's one type of copper IUD available in the US, and that is called the Paragard IUD, and is or called copper T380. And the 380 really refers to the surface area of the copper, which is around 380 millimeters square. And that surface area affects the duration of the effectiveness of the contraception. The copper IUD is FDA approved for 10 years, but there's good evidence that supports its use for continuation for up to 12 years, and we'll talk a little bit more about that evidence as well. The high efficacy of the IUD really suggests that there's multiple mechanisms of action that's responsible for preventing pregnancy. All IUDs really do create an inflammatory response that creates an overall spermicidal environment. And the inflammatory cells really act as phagocytes to the sperm, like back in the days when you used to talk about phagocytosis. The copper IUD releases the copper-free salt that has direct spermicidal effect, and the copper also alters the cervical mucus and also the endometrial secretions. Copper IUD is also used as an emergency contraception, and the contragestive or inhibition of implantation. And if following an unprotected intercourse, the copper is effective for preventing pregnancy for up to 5 days, or in the test question, it's normally they put 120 hours to trip you up. So 120 hours after ovulation, but that's 5 days. So the World Health Organization did a study in 1997 that showed no pregnancies between 8 and 12 years of use of the copper IUD. And though these studies are reassuring, the contracepting efficacy of the copper IUD, it shows that it can go up for as far as 20 years of use. The generalizability of these, though, are kind of limited because the study's inclusion criteria only included women who were 35 years and older. And then in the Rose study, they only included nulliparous women. Overall, though, the data does support continuation for the efficacy of the copper IUD for 2 additional years, with some evidence for additionally 5 years. So we should be counseling our patient that there's good evidence that supports the contraceptive use for the copper IUD for at least 10 to 12 years, so past the FDA approval date. We're going to switch gears and talk about the levonorgestrel IUDs now. And as previously suggested, there are 4 types that are available in the United States. The Mirena IUD and the Liletta IUD contain levonorgestrel hormone, and it's 52 milligrams. Both have the same dosage of levonorgestrel, and both release 20 micrograms daily, and both have been now FDA approved for pregnancy prevention for up to 8 years. The Kyleena has 19.5 milligrams and is FDA approved for prevention of pregnancy for up to 5 years. Skyla is the lowest of all the levonorgestrel doses, and that's 13.5, and that's approved for pregnancy prevention for up to 3 years. Like the copper IUD, the inflammatory response created by the foreign body induces a spermicidal effect from the levonorgestrel. The levonorgestrel also works by thickening the cervical mucus. And the levonorgestrel hormone leads to atrophy on the endometrial glands and downregulation of the progesterone receptors, which causes a decreased response to estrogen. And this is also the mechanism that causes the decreased bleeding that's normally associated with levonorgestrel IUD. There is some decrease in ovulation function in the first year, but this is not the mechanism for which the levonorgestrel IUD it works to prevent pregnancy, and 50 to 75% of women ovulate after the first year. So we really want to not tell patients that it works to prevent ovarian cyst formation. So this slide is looking at the differences between the levonorgestrel IUD and the copper IUD. The levonorgestrel IUD is slightly more effective with a lower failure rate. The risk of perforation, the number that I use when I'm counseling patients, is the 1 in 1,000 per insertion. And then expulsion rate is dependent on the time of insertion. So if you're doing an interval, which is normally what we do most commonly, it's normally 1 to 10%. Post-abortal is 0.8 to 4%. And then immediate postpartum mark, which will be coming our way soon. So mentally take these numbers down in your head for your counseling. Levonorgestrel has a higher expulsion rate at around 27%, and the copper IUD is around 12%. Sorry. Here, we're just looking at some of the associated benefits and some of the associated side effects that are associated with the levonorgestrel versus copper IUD. The levonorgestrel can cause amenorrhea in 1 of 5 users, and also can cause some nausea, some headache side effects. The copper IUD, the most common counseling point is that it makes the menstrual cycle a little bit heavier, and they can have some dysmenorrhea. Additionally, the benefits is that the copper IUD is an emergency contraception, but in a slide down from this, we're going to talk about the levonorgestrel also being emergency contraception. But the levonorgestrel works also to improve your dysmenorrhea, menorrhagia, chronic anemia, and is also used for people that have endometrial cancer and to reduce endometrial cancer risk. So let's talk about levonorgestrel versus copper IUD as emergency contraception. A study was done by Turk et al. Out of Utah that was a randomized non-inferior trial in which participants were unaware of the group assignments, and it was conducted at 6 clinics in Utah, including women who were seeking emergency contraception after at least 1 episode of unprotected intercourse within 5 days before presentation, and agreed for IUD placement. They were randomly assigned to participate 1-to-1 ratio to receive either the levonorgestrel IUD, and the one that they used here was the Liletta or the copper IUD. The primary outcome was a positive pregnancy test 1 month after insertion, and when a 1-month pregnancy test was not available, they did a survey of the patient, or they looked in the medical records to see if there was a pregnancy status noted in the patient's medical record. The eligibility criteria were women between the ages of 18 to 35 who were English speaking or fluent in Spanish, who were requesting emergency contraception after unprotected intercourse for 5 days. Also, if they were interested in initiating an IUD, if they desired to prevent pregnancy for at least 1 year, if they had a negative pregnancy test at the time of insertion, a history of regular menstrual cycles, meaning from 21 days to 35 days was what they consider regular cycles in their study, and then a known date for their last menstrual period, plus or minus 3 days. And on the basis of their menstrual history, they were able to calculate where they were in their menstrual cycle at the time of insertion to determine whether or not they were pregnant. Basically, the study results showed that the levonorgestrel IUD was non-inferior to that of the copper IUD for emergency contraception. And in fact, only one person or one participant rather in the study was found to be pregnant, and it was determined that that participant was pregnant prior to the study. Here we're looking at the rates of amenorrhea, and this really shows that the levonorgestrel has the highest rate of amenorrhea in the first year, but it's not a 100% thing. So when you're counseling your patient, the chances of becoming amenorrheic in the first year is 20%. It significantly increases as the years go on. And then with the Kylena, there is still a significant rate for amenorrhea, up to 12%, and at year 3, 20%. So I feel like sometimes our counseling for the Liletta or the Mirena versus the Kylena is that, oh, the Kylena, you'll still get your period, but if a couple of the patients will become amenorrheic. So we just need to be cognizant of that while we're counseling our patients and be mindful of telling them that as well. There were some retrospective chart reviews looking at levonorgestrel IUD and patients who were continuing the device for 60 months to a maximum of 15 years from the placement. 160 were using the levonorgestrel IUD beyond 7 years, which resulted in a cumulative 1,403 women years of exposure and up to 15 years with no pregnancy reported. And of the 160, you had 96 that used it for 8 to 9 years, 31 for 10 to 11 years, 17 for 12 to 13 years, and 16, 14 to 15 years. Most of the women had ongoing increased rates of amenorrhea after 7 years, suggesting that the effect of the levonorgestrel IUD continued to create an amenorrheic environment after, and none of the women got pregnant during these years of use. There's currently a phase 3 trial that is multi-center, that is ongoing by Liletta for use for up to 10 years. And so far, the preliminary data suggests that there is effectiveness and safety for up to 8 years. That's why they were able to get FDA approval for 8 year. Of that, 478 women completed 7 years, 343 completed 8 years, and in the 7 years, there were only 2 pregnancy. One was an ectopic pregnancy, and the other was one implantation that occurred 4 days after removal of the IUD. And there was no pregnancy noted in year 8. And the amenorrhea rate increased to 39% between year 7 and year 8. So, what are some complications that might be associated with IUD or that we should discuss with our patient? In the first 20 days after placement, there might be a slight increased risk of having an infection. There is no association between bacterial vaginosis and the IUDs. Patients should be tested for gonorrhea and chlamydia at the time of insertion of their IUD and should be treated according to the CDC guidelines. If someone has PID and they have an IUD in place, we should leave the IUD in place and treat their PID in accordance to the CDC guidelines. If, however, the patient is not clinically improving within 48 to 72 hours, we can consider removal of the IUD. Similarly, if someone has a TOA and has an IUD in place and they aren't clinically improving within 48 to 72 hours, we can also consider removal of the IUD. But important to note that we should not remove, if someone's septic with a TOA, we should not remove the IUD before starting their antibiotics. Pregnancies with an IUD in place. So ectopic pregnancy rate overall is decreased by an IUD. The rate is zero point 0.2 for women, zero point 0.2 per 1,000 women with IUD in place. However, the counseling is that if you do have an IUD in place, the chances of you having a pregnancy inside the uterus is less likely, and it's more likely to be an ectopic pregnancy. If there's a pregnancy that's intrauterine, then the risk associated with that pregnancy is a risk for spontaneous abortion. There's a risk for preterm birth. There's a risk for choreo or placental abruption. There is no association at all with congenital anomalies. So for your interval insertion of your IUDs, you really want to counsel the patient about when the IUD will start to work. And from our prior slides, we see that they both start to work immediately after placement, meaning both, I mean, the Mirena IUD or Laletta and the copper IUD. You want to discuss the changing in their bleeding profile that they might experience. You want to tell them that there is ectopic pregnancies are rare, but if they do become pregnant, it is definitely an increased risk for it to be an ectopic pregnancy. Discuss the risk of expulsion, the risk of perforation. The risk of perforation is increased if the woman is breastfeeding. So if you have a postpartum interval IUD insertion and the patient is breastfeeding, the risk of their uterus being perforated is sixfold. So just be a little bit more gentle with your uterus during that insertion. And then if you have a less experienced clinician, then the risk also doubles. Intrauterine contraception can be inserted at any time during the menstrual cycle, as long as the provider is reasonably certain that the woman is not pregnant. The practice of inserting the intrauterine contraception only during menses is unnecessary and really is inconvenient for the patient. So when the copper T is being used for emergency contraception, we want to rule out existing pregnancies by history or by our urine pregnancy test if indicated. We would basically recommend that you follow this guideline. For women who cannot be reasonably certain, you want to counsel them about the risk of placing the IUD if pregnant and offer a bridging method. And really, what we do in our family planning clinic is that we talk to the patient about placement based on patient-centered approach, which is focused around their pregnancy intention and what they would do if they were to learn that they were pregnant when the IUD, after the IUD was inserted. So really making it a patient-centered counseling. What do you do after you insert your IUD? Really not much. You don't need to do a routine string check anymore. Really, all you want to do is to counsel the patient that if they have any concerns about their IUD or if they desire to remove their IUD, that they should follow up. So what are some mechanical complications that can occur with an IUD? Mechanics kind of sound like it's a car, but it's not. It's a really good tool though. Um, so the IUD can become embedded. If it is embedded, it normally is diagnosed really by an ultrasound, and it should preferably be a 3D ultrasound to confirm whether or not it's partial or fully embedded. Partially embedded or IUDs and patients that are asymptomatic doesn't require any kind of intervention, so they can keep their IUD if it's only partially embedded. If it is fully embedded, you want to initially try to remove the IUD in your office. There was a study that looked at removing it in the office, especially with a subspecialty clinic, and they showed that 80% of the IUDs that were fully embedded were removed successfully in the office using an instrument that's called an alligator forceps. Before, when the IUDs, you know how I showed that slide with all the different types of IUDs, when we had the circular IUDs, the hook was very good because the hook could hook around the circle and pull the IUDs to us. But the difference now is that all of our IUDs that we're using within the United States have a stem. And so it's hard to get the hook around the stem. But with the alligator forceps, like my fingers, it literally has a beak like an alligator. And so you can really go into the cervix under ultrasound guidance, grab the base of your IUD and just pull it out very easily. So that's why removing it in the office is much easier. And if that doesn't happen, then you will take them to the OR. It's very similar to the hysteroscopic forceps that you use, the alligator forceps. They're longer, they're long, but not as long as the hysteroscopic ones. If the IUD is missing, then you want to do an ultrasound to see if you can see your IUD. If you're not able to see your IUD on ultrasound, then you should have a concern for perforation of the IUD, and then you should obtain an x-ray. The x-ray that you want to get, you want to make sure that you can see both diaphragmatic borders, and then you want to do a complete pelvis x-ray. And if the IUD is indeed perforated, then you want to make sure that you do laparoscopic procedure to remove your IUD. So the World Health Organization also has their mix criteria, and it was because of their mix criteria, making postpartum IUD category one, that the government in the United States had a great uptake to it, and we were now able to offer these services. Um, in the state of New Jersey, so far, we've not been so successful in offering postpartum IUDs, mostly because of some stipulation that was made in the Medicaid released statements that we've been working around how to make sure that reimbursement is a possibility when we do our services for it. But in other states, they've been successful in implementing postpartum IUD, like in states like New York, where I trained, we did postpartum IUDs all the time. The reason why postpartum IUDs are important is that 30 to 60% of people will resume intercourse before even coming for their 6 weeks visit. And if they are not breastfeeding, they will ovulate by 21 days, or probably around that time frame, they'll ovulate. And so a pregnancy can happen very closely after a vaginal or a C-section delivery. So the device can be placed within 10 minutes after the placenta is delivered. It increases access really to patients that aren't able to make the postpartum visit. The no-show rate for postpartum is visits are very high, and only around 25% of patients actually come for their postpartum visits. So that's low. What are some contraindication to doing this immediate postpartum? If the person has an intrapartum fever of greater than 38 degrees Celsius, if there was a rupture that occurred greater than 24 hours, and you're concerned for chorioamnionitis, the patient had fetal tachycardia or some kind of fundal tenderness, that would not be a good person to get this. If there's a known anomaly of the uterus, or the uterine cavity is deformed either by a fibroids, or if they have some kind of septate or didelphys uterus, then this would not be a good candidate. If they have ongoing postpartum hemorrhage that is not being effectively controlled by medication, then they're not a good candidate for postpartum, immediate postpartum. And of course, if they have medical indication to the postpartum IUDs that you might be offering. This picture is just showing how we will be doing our training with the Mama U uterus, which is basically just a bigger uterus, a postpartum uterus, so that we can get the idea of what we need to do. This midwife is using a ring forceps to insert it, because we can't use the introducer because the uterus is just so big that the introducer would just get lost. So we just take it out of the introducer and use a ring forceps to insert it at the time after delivery. Expulsion rates vary by mode of delivery, as in vaginal versus C-section, and the type of IUD. So after a vaginal delivery, expulsion rates can be high as 30%, but after a C-section, as low as 8%. And then the expulsion rate, as we saw in previous slides, are higher with the levonorgestrel system than it is with the copper IUD system. Excuse me. Women should be counseled about the possibility of expulsion um, when you're talking to them about their postpartum IUD and other associated symptoms, like if it's placed at the time of a C-section, they might not be able to feel the strings, because unless the provider uses the ring forceps to push the strings all the way through, and you don't want to use the ring forceps and then bring it back up into your clean field. So most providers will not. They might not be able to feel the strings at the if it's placed after a C-section. The strings will lengthen if placed after a vaginal delivery, because the uterus is so big that there's not much room for you to cut the strings. So they should, that's the one time that you tell them to come back for their postpartum visit for a string cut, or a string check rather, because you can cut the strings at that time. And then of course they're postpartum, so we want to talk to them about what effect, if any, this would have on their breastfeeding. And so far we know the copper IUD has no effect, and there was a small study that was done by Turk et al. Out of Utah that shows that there was no effect also on the quantity and the quality of breast milk from with the levonorgestrel IUD inserted immediate postpartum. Post-abortion, it can be used immediately post-abortion too, after first and second trimester. It really does decrease the rate of repeat abortion, decreasing it 20 folds. But you also want to talk about expulsion rates, because the expulsion rate is slightly higher when placed immediately after an abortion. This graphic is really indicating the return of fertility after removal of your intrauterine device, and it's basically showing that it's similar to that of discontinuation of a barrier method. There is limited evidence that suggests that the levonorgestrel IUD may be beneficial in women who have a fibroid uterus, who have endometriosis, who has adenomyosis, who has endometrial hyperplasia, and also who has endometrial cancer, who are not surgical candidate. And we've certainly placed in our both sites in GYN Clinic and in the CAB for endometrial cancer patients that aren't surgical candidates. We're going to switch gears now and talk about our next LARC that's available within the United States, and that is the contraceptive implant, also called Nexplanon. So there's the ethanogestrel implant, which is the Nexplanon, and that one is a single rod. But I put in this slide the Jadel, which is a two-rod levonorgestrel system that's good for 5 years, only because I know that we have lots of people from the Caribbean and Latin America that we see coming into our clinics, and they most commonly will have the Jadel. The removal and the insertion of the Jadel is very similar to that of the Nexplanon, except if you could see my arm, it's like a V with my fingers on, and that's how it will feel on the when you feel it in their arms. And to remove it, you'll just make your one incision like you would your next one on, and both rods should be able to be removed through that one incision. Both do contain the barium sulfate, so you should be able to find them on ultrasound, which the Nexplanon is FDA approved for 3 years, and there is good evidence to support extended use for 5 years, which we'll talk about a little bit more in the presentation. How does it work? It suppresses the LH surge, and by that, the levels of inhibited ovulation is normally achieved as soon as within 8 hours after insertion. It thickens their cervical mucus, and it can cause also some endometrial atrophy. The failure rate for or ethanogestrel IUD, I'm just going to call it Nexplanon because it's so long. So I'm just going to say Nexplanon is 0.05%, and it's the most effective form of contraception that we have. It's more effective than tubal ligation. When counseling your patients, you want to talk about the bleeding that might be associated with the Nexplanon device. And so the progestin implant has really this very unpredictable and variable irregular bleeding. Bleeding usually remains irregular if you initially start with an irregular bleeding profile, but there are some people that will end up that can become amenorrheic with the implant. And then you can also use estrogen containing contraception to help with that irregular bleeding profile. However, there's some evidence to show that once you stop the estrogen containing contraception, that sometimes that irregular bleeding profile does return. But it's something to try before taking a really good contraception. Another thing that you want to look at and talk to your patients about is what medications that they're taking. So if they're taking a medication that induces the cytochrome P450 pathway, that will lower the effect of the progestin and therefore increase the risk for pregnancy. So here I just listed a few that we might commonly encounter within our clinic, but it's just something to keep in mind. And in fact, our app that I spoke about earlier, also in this red box, highlights some of the commonly used medications that we might have. So if you're ever seeing a patient that might be on one of these, you can quickly run to the app and be like, is it going to affect their contraception, and get a quick answer. Other counseling things that you want to talk to them about is weight gain. There was a prospective study that was done out of that good study, the contraceptive choice study, comparing ethanogestrel users to copper IUD users at year one. They saw that the mean weight gain for the Nexplanon users were 2.1 kilograms and 0.2 for the copper IUD users. But what they found is that after they adjusted for confounders, there was no significant difference. Acne is also a common side effect that might occur. We're not sure exactly what the association is between the acne, and we know that if you give concurrent estrogen contraception, it can help to clear up the acne. Importantly, the FSH is not suppressed, and therefore follicular development does occur when someone is using the Nexplanon. Though cysts are rare, it can occur. So we just need to keep that in mind, because sometimes we are counseling patients that they won't get any cyst and the Nexplanon is good, but they can rarely get a cyst formation. Rare though. How do we insert the device? I thought this was important for us to talk about because I know some of us are old schoolers, and so we probably remember the old school way of inserting the device, but lots of change since then. Still, it's going to be 8 to 10 centimeters from the proximal to the medial epicondyle, but now we're doing it 3 to 5 centimeters away from that sulcal groove. So you want to ask your patient to make a muscle. See my guns? And then you feel for the groove right here. You don't want to insert it in the groove. You want to go a little bit below the groove. So 3 centimeters. Just be cognizant that if someone is bigger, you don't want to go exactly three centimeters because it might end up under here. If someone's smaller, you don't want to, you just need to be mindful of that, but just don't insert it in the groove is the moral of the story. Especially with our shorter Spanish women, their arms are a little bit tinier, so we have to be a little bit unique with how we're inserting it. Another important thing is that when you're inserting it, you want to maintain less than 30-degree angle to avoid deep insertion, which is another complication that can occur with the Nexplanon if inserted incorrectly. So some complications that can occur is that you can have infection. If not inserted all the way, the device can expose. So if you insert it and there's still a little white piece, you need to take out that white piece and insert a new one because it will fall out. They can have local irritation at the site, so that's something that you want to talk to them about. And then oftentimes, if it's deep and you can't palpate it, you need to refer these patients to a specialty trained individual for ultrasound guided removal of the Nexplanon. Immediate postpartum, it's safe. It's category 1 in non-breastfeeding, and then category 2 in breastfeeding. There was a study that was done by Levy et al. At Montefiore, the different Montefiore medical sites, that looked at the quantity and quality of breast milk and induction of breastfeeding during the insertion, and it showed that there was no impact on breastfeeding. So it's safe for women that are breastfeeding to get their Nexplanon inserted. The implant may also be inserted safely after a first or second trimester abortion. Important to note is that you can also give the implant, you can insert it at the time of medication abortion. And by that, I mean the day that you're giving them their mifepristone, if you're counseling them about contraception, you can insert their Nexplanon at that time because there's no increased risk that for abortion to fail if you insert the Nexplanon and they take their mifepristone. Well, if we still have mifepristone, but we still do in New Jersey right now, so we'll still continue to say that. Al et al. They conducted a randomized study in 7 countries comparing safety and efficacy of the single rod ethanogestrel implant and also of the 2-rod levonorgestrel implant, um, comparing it to the copper IUD for 5 years. 204 women were assigned to the ethanogestrel implant that completed 5-year use, and the cumulative pregnancy rate over 5 years for the implant was 0.6, with all attributing pregnancies occurring in the first 3 years of use. So there were no additional pregnancies that occurred in year 4 or year 5. Also, a study that was done in the United States describing the extended use of the Nexplanon, in which 50% of the study participant had a BMI over 30. Research followed the 291 patients past year 3. 102 women used it for at least 24 additional months. There was no pregnancy. So there's no difference between the medium serum ethanogestrel levels across the different BMI groups between year 3 and year 5. And now currently Merck is doing a multi-center, multi-country phase 3 clinical trial prospective study evaluating the extended use of Nexplanon for up to 5 years, with hope that when the time for their renewing of their FDA approval, I think it's coming up in the next year to 2 years, that they can extend the use of the Nexplanon for up to 5 years. So hopefully soon to come. This is just looking a little bit more at the study that showed what the bleeding profile will look like for the LARCs in the extended years of use. And we can see here for the levonorgestrel IUDs, within the first year, on average, 18% of people will be amenorrheic, but by the time you get to year 5 and year 6, you reach as high as 40%. And then by year 7 users, it's around 62% of people that are amenorrheic. So, contrary to popular belief, the longer you keep your levonorgestrel IUD in, the less bleeding you'll have, which makes sense. For the ethanogestrel, the rate for amenorrhea in the first 2 years is approximately 22%, but during year 4 and year 5 of the extended use, the amenorrhea rate is not that great. It's around 8% of users. And then some users can experience heavy bleeding around 12%, and then irregular bleeding for around 46% of users. So I normally counsel my patients that in between year 3 and year 5, if you start to experience irregular bleeding that becomes bothersome to you, you are welcome to return to our clinic, and we can certainly remove the device and put a new one in. So how do you center how do we center patient preference in our counseling when we're talking about extended LARC use? You want to make sure that you're discussing and reviewing the device extended use profile. You want to counsel about the extended use should be centered really about what's the patient priority. Like, do they want to remove it? If they were to keep it, how long do they want to keep it for? You want to talk to them about the bleeding changes that they might experience. You want to make sure that you don't take out this and then put them on a short acting contraception to then have them get their long acting contraception. Like while they're waiting, like this interval waiting for their IUDs to come, you're putting them on birth control pills. For people that haven't taken birth control pills in a long time, that's an easy remedy to mess up and get pregnant. And in this time that we're living in, we don't want any chances with our patients because we don't want women to have to struggle more than they already are. And for some women, cost is a factor, right? So we want to figure out whether or not it's too costly for them to have it replaced. And definitely, we see good evidence that shows that it doesn't matter their size, it's really good for up to 5 years. So, in summary, after all of that, we know that LARC methods are effective contraceptions. There are a few contraindications to them. They can be safely initiated at any time for the appropriate candidate, be it interval, immediately postpartum, or post abortion. Women should be counseled about their risk and their benefits prior to initiation. And we should definitely be talking about extended use with our patients and remembering that extended use is safe. At this time, as we continue the fight, I will take any questions.
Thank you, Dr. Matthews. Thank you for that excellent grand rounds. Are there any questions?
Glenmarie.
Hi.
Yes, go ahead, Dr. Marjanian.
We can't hear you.
Glenmarie, can you hear me?
Yeah.
We hear you now.
Oh, I'm sorry. Thank you for the presentation. I was just wondering, what are some of the regimens that you offer patients when they have breakthrough bleeding on, for example, the Mirena?
Yeah. So you're finished with your question?
Yes.
Oh, okay. Some of the regimens that we offer is that you can do ibuprofen or an NSAID for the first few days of the bleeding and see if that will work. And then also I offer them continuous, if there is no contraindication to estrogen, I offer them combined oral contraception just because the estrogen can help to stabilize the endometrial lining. And it really is effective to get them over that annoying window of that intermediate spotting, and then eventually their body will get into a good pattern of just having that one bleeding. If, however, like most of the patients I see have contraindication to estrogen, they've gotten clots, there's just so much. Then what I have been doing, but there's no study to prove this, this is antidotal. I'm actually working with Adam to see if we can get a study on this, a randomized study. I've been giving them agestin, and the agestin has really been helping to maintain the menstrual bleeding for only once a month. And then normally when I stop the agestin, they're in that pattern of just having bleeding for once a month, especially for women that I'm putting it in for adenomyosis or for fibroid uterus is what I've been doing.
So what dose and for how long with the agestin?
For the agestin, I've been doing 5 milligrams BID, and I normally do it for 2 months to have 2 cycles that is regulated.
I see that Dr. Levine has his hand up.
Oh, thanks for joining, Dr. Levine. Oh, you're muted.
Sorry about that. Anyway, as always, wonderful presentation and always a pleasure working with you and Willie. I just want to know if you could just comment about what's in package inserts for the levonorgestrel IUDs about ovarian cyst formation, because I find a lot of providers misunderstand that as a side effect rather than just a consequence of all the ultrasounds that were done during the studies. And I just find that that gets perpetuated and often a reason they don't recommend it for patients.
Yeah, and so that's why I brought that up in the slides. I already discontinued my slides, but I brought that up in the slides earlier to say that, you know, the levonorgestrel IUD, there is a chance that you will get cyst formation in the first year, less likely, but however, in the subsequent years, there's normally 50 to 75% of women that are ovulating. And so just like any normal ovulating woman, you get a cyst on your ovary every month, and sometimes you have a little bit of bleeding. So I normally tell the patients that this is not, and when they come in, I don't say that it's because of the levonorgestrel IUD that you're having the cyst formation. I discuss what your menstrual cycle is about and why you get a cyst and how a cyst can be formed, and then discuss that the levonorgestrel IUD does not prevent that. So like talking to the patients around what prevents it, how it can occur, they're like, oh, okay, because I feel like sometimes the providers are like, oh, I can put this IUD in and it will prevent it, but it's not in fact true.
No, thank you. And I really appreciate you mentioning about getting women in earlier postpartum, because so many of them are ovulating before that 6-week postpartum visit. So thank you.
Yes. And then if we can really start doing this immediate postpartum work, which I have hope that it will be before the year 2023 is out. That's my self goal that I set for myself. And normally when I set goals for myself, it happens. In Robert Wood, we will be taking good care of our women.
I see that Dr. DeScenzo has her hand up.
Hi. Two questions. One, I was just curious if we know why the copper IUD is less likely to be expelled compared to the levonorgestrel IUD, like for immediate postpartum marks. And number two, what is your advice for avoiding coercion when talking to our patients about how amazing LARCs are?
Okay, so number one, when I was a resident, I did a meta-analysis trying to figure out why the copper IUD was exposed less than the Mirena IUD, and I could not find any reason as to why one was exposed less. So I don't have the answer to that one. So that was easy for me because I don't have the answer. I'll probably have to do another study. But these are all great study ideas, Natalie, so we could do studies together. Um, Two, to your question, really when we're talking to patients about contraception, and I kept saying that, like patient centered, I was serious. Like you have to figure out with your patient, what do they want? What are their intention? Really tease out of them what they want for their future, what their intentions are for pregnancy. And then once you figure that out, talk to them about their menstrual cycle, kind of get an understanding of their menstrual cycle. And once you tease that out and you talk to them about all the contraception options, you allow the patient then to really come in and say, oh, yeah, so since I want this for a longer time, maybe I'll try this one. So, really, you're never saying, I think you should get this one, because really you're having a discussion with the patient to see what their intentions are, and they are ultimately making the decision. So, every time I counsel a patient, I'm like, I can't make the decision for you. Here are the options. I think you're a good candidate for either one of these because you have no contraindication, but and we won't know where you fit on the spectrum, especially for the next one on. I can't guarantee that you're not going to have bleeding in between your menstrual cycle, but you're a good candidate for it. If this is something that you would like to try, I'm willing to offer it to you today. Right? So I'm not saying you must get the next one on, you're young, you need this. No, I'm saying here are the options. And if she's like, no, I just want to do birth control pills, I was like, I'll give the birth control pills and say, well, if you find that you're missing more than 2 pills in a pack, then that means you need to come back and visit Dr. Matthews, because maybe you're not such a good pill taker and we need to talk about some other great options. So she feels empowered that I'm giving her the pill and I'm empowering her to say, hey, you know, if I feel like I'm not doing this right, I can come back to Dr. Matthews. Any other questions?
All right. Well, Dr. Matthews, thank you so much. I hope everyone has a safe and productive day.
Thank you, everyone.